Like guys using it a lot. I think it's quite very.
It worked on enough. We're starting to use them for trying to capture areas where we can build more. So using some of the like.
We did
Those have their limitations. Right now.
We're talking about like the audio in Sacramento. Map, are you using the Microsoft one or?
Yeah, we have to.
Okay.
Hey, I'm good. Hey, I'm good. It's good.
Yeah.
They're having some very interesting conversations. So, yeah, it's like CEO job.
There's so many like. Oh, we'll go on someone locally, but what if someone has to be stable or whatever?
He's the trend.
They're like, if someone use anything except for DAX.
Sit down. Yeah.
The amount of good catching in there. Location to go down there, one
France, right?
like 1B among this thing.
That's it. That's no idea what's happening in these companies.
You open achieving in the patient.
Literally, that's like a direct question. Yes, listen, I'll give you a call. Yeah, so and you like in about
That's the primary.
We have a switch for you.
Okay, it's not what we want. So I'll connect to the market. Yeah.
So how did you feel about your presentation this morning?
Yeah. Saying you spoke. Yeah,
But answer a time. I know it's gonna come my face. It's quite like.
Yeah.
Final difference.
So yeah, I will see how I can actually make it. Every aspect we did about how I just do my walking now. Yeah, if you're on. What do you want to
So once we're back,
Hey,
it's really IG.
That's great.
I don't know. Say,
Yes. How are you? Is that social? No. Yeah, I'm seeing you guys. Yeah.
yeah.
It was good. No, I was here. I'm just relaxed.
You can just be like grab the lunch and still walking out.
Hey, I'm like.
Every time, yeah. Like, we have to text everybody. Visa sponsorship plan भी लोगों ने बना सकते
Pleasure with business.
Visa sponsorship.
Got my buzz. I know.
You don't need it.
Essential something. Yeah. Like, yeah. Yeah.
Yeah, so we think that is. Similar to what. Like the self-provision model. Data. You contact the principal.
No, you can actually access it.
They don't want you to actually.
Yeah.
There's like a third party that will.
It's kind of a full house.
So it's like.
Last, but it was for the viewers. Very relevant. Yeah, that one I've actually seen her talk before. Thanks. So that's what I was like. Yeah. Yeah, did you go to that like AI cancer some weeks ago? Because that's where I got exposed to her.
Thank you all for. I'm here in the afternoon. I'm not a morning person. I want.
Yeah, she's one year, right?
I just think that's.
People online, this is a lot of sensible interest because I don't know if y'all know, there's a lot of crazy stuff going on in the world right now, and it's hard to keep up with everything that's actually happening. It's a special set put together by some people from what we're calling the Orion Network. It's really a multi-site collaboration across multiple sites. Stanford, Harvard, many others. And what this will kind of largely be is kind of, you could call it a literature review of like major events in clinical AI science over the past year. Peter and Liam are going to introduce themselves. They're going to be presenting a lot of this. And I'll tell you now, this is going to be an absolute whirlwind tour. If you will not be able to keep up, it's going to fly by with intense information very quickly. The full extended report, there's like a 130-slide report beyond be online. But in the meantime, we're going to do some highlights here just to whet your appetite about what you're going to be thinking about, pay attention to. I know there's background noise that people can kind of peter out, but I'm going to mute the room so that we can focus online. With that in mind, Peter, do you want to go ahead and just take it away?
Somebody there already.
Yeah, absolutely. All right. So thanks for the introduction, John. As John mentioned, we are the Arise Network, a collaboration across Stanford and Harvard, and again, performing somewhat of a literature review and definitely going to be a whirlwind tour today. Here are the authors. I'll just introduce myself briefly. I am a rising cardiology fellow here at the Beth Israel in Boston, where I'm currently an internal medicine resident in my last year. I'm an affiliate of the Arise Network and former life sciences strategy consultant. My research now focuses on human-computer interaction and LM clinical reasoning. And I'd like to thank you guys all for joining me here today. It's a real pleasure to present to you, and I'm super excited to share the work we've done over the past couple of months and provide a real review over the last year. I'd also like to thank all of my co-authors and reviewers. It wouldn't have been possible without their help. So as John mentioned, if you followed the news lately, you've seen a lot of stuff happen. The FDA has announced it's going to loosen the belt when it comes to clinical decision support tools, as long as the clinician maintains decision-making autonomy. And additionally, likely, they'll loosen the belt when it comes to wearable devices, as long as the wearable devices promote just information and claim not to be medical grade. Two major frontier labs have made big plays in the past couple of weeks, OpenAI and Anthropic launching consumer-facing chatbots, as well as making a play into operational workflows in healthcare systems. And lastly, we've seen the state of Utah enter into a pilot with Doctronic, evaluating whether AI can provide autonomous medication refills. So that's a lot of activity just in the first couple of weeks in 2026. And I'd like to say, how can we make sense of all this? And hopefully by the end of this report, what moves are being made in the industry, hopefully have a little bit more context. But let's start first with just establishing just some background information. So the FDA has already approved greater than 1,200 AI ML tools, yet a minority of them undergo peer-reviewed evaluation. When the FDA promotes their FDA device summaries, less than half have study designs, greater than 95% of them don't even have demographic data. And so that's sort of the motivation for this report, bringing the focus away from the hype of AI and bringing it back towards evidence-based medicine, which is the gold standard for medical practice. And my promise to you as an audience during this presentation is to be as unbiased as possible and really objectively tell you straight up where the field is at the current moment and where we're going from here. And so to really synthesize clinical AI in the past year, we've bucketed into 6 core themes. The first being model performance. We'll talk about reasoning models and the new wave of those models, benchmarks and evaluations. What standards are we holding models to, and how do we track progress over time? Foundational methods. We'll review some novel methods that folks are using to beat off-the-shelf models. We'll talk about AI in clinical workflows, which is the nitty-gritty of the human-computer interaction, putting doctors in front of LLMs. Patient-facing AI, which is a new wave of patient engagement, and applied AI demos, where we'll end on showing you some subspecialty use cases as well as some new tech to come. And again, I'll just reiterate, this report is very dense, and I also talk fast, so it's going to cover many topics, but I would just defer you to the full report for additional details. So you don't need to read this slide, but here's our general approach. By no means is this a systematic review. We searched PubMed articles for peer-reviewed data, as well as preprint servers. And preprint servers are playing an increasingly prominent role in this realm. It's really difficult for peer-reviewed journals to keep up with all the model evolutions, so I'm sure you can appreciate that. And we additionally called on colleagues from academic institutions around the globe to submit high-impact studies, as well as folks on social media. And all those reviewers and authors who you have previously seen have reviewed all these studies. And we really focused on clinician and patient-facing AI, less so on non-clinical AI, such as like drug discovery or biotech. So let's jump into it. So model performance, well, we'll talk about reasoning models. And let's start off with the inaugural large-scale reasoning model, which is the O1 series by OpenAI. And with the advent of reasoning models, this begs the natural question, how do they perform with clinical reasoning? And this study ran O1 through a series of clinical reasoning tasks, compared it to non-reasoning models, GPT-4, humans with GPT-4, as well as a human baseline. And on this suite of clinical reasoning tasks, O1 actually outperforms GPT-4, humans with GPT-4, specifically within management reasoning, as you see on the left side of the screen here. Now, what's unique to this study, additionally, is that they pulled down real-world data from ED cases at the Beth Israel here in Boston, and that was unstructured data. And they put O1 through diagnostic reasoning against attending physicians, and they found that O1 outperformed them at certain touch points, the initial ER triage, at the end of the ED encounter, and performed at the level of the human physicians at the point of admission. But the real world doesn't really come in the form of nicely packaged clinical vignettes like we just showed. In comes Google with their conversational AI, Ami, and Ami really is a fast dialogue agent to collect history from a patient. It then includes a slow management reasoning agent as well. And both of them are state aware. And what I mean by state aware is they have a reference to a continuously running patient summary, differential diagnosis, as well as a management plan to determine their next steps in the conversation. And in this simulated setting of longitudinal care, in this case, it was 3 clinic visits, Ami was non-inferior to primary care doctors in tenets such as overall appropriateness. And you can appreciate how even early on in like the first clinic visit that Ami was outperforming these PCPs. And Ami was shown to be a little bit more precise than the PCPs, able to name the antibiotic, not even just that, but also the dose, total time course, and monitoring parameters, which I think previous models weren't able to appreciate that much detail. And I think this really shows the possibility of agentic AI serving as perhaps a point of continuity in a fragmented healthcare system. So we've shown a couple of examples of maybe dare I say, like superhuman knowledge, superhuman reasoning, and those are in controlled tasks. And I wonder, is there a way to stress test this? And this is a clever study design where researchers took multiple choice questions, changed the correct answer to none of the other answers. Now you can appreciate how just the pattern of answers has changed. The underlying reasoning trace to arrive at the correct answer hasn't. They tested models like O3 Mini, GPT-4o, and they found that performance dropped significantly when it was changed to none of the other answers. And so that makes you question, is what we're seeing and appreciating as clinical reasoning really just surface level pattern recognition? And I'd also argue that a clinical tool that drops in performance in such a manner might be, dare I say, clinically unreliable because and you can probably imagine there's multiple presentations of the same disease state. And so with novel presentations, do these models collapse a little bit when they're not able to see the pattern that they're used to? Now, the fragility in reasoning was further shown in a study looking at script concordance testing, which is testing how and when doctors update their decision-making based on new information that becomes available. And with this evaluation, LLMs generally performed at the level of medical students, but underperformed relative to residents and attendings. And additionally, you can see on the left side here, a nice normal distribution with what was supposed to be the correct answers and the correct ratings for how new information changed their decisions. You can appreciate just the bimodal distribution across all of the LLMs. They tend to make very provocative ratings in terms of how new information might change their decision-making, either very unlikely or very likely, rarely selecting neutrality. And I think this provides motivation for models to be needing to be a little bit more aware of their own uncertainty. And so here are some takeaways from this section: that models have shown some signs of superhuman reasoning abilities, but these are in very controlled tasks and also seems to be a bit fragile. And models need to be a little bit more aware of their own uncertainty. We also see evidence of superhuman abilities in those controlled tasks. And so if we're just comparing it to a human baseline, is that the incorrect standard to use? Perhaps we should think about evaluating models to higher standards rather than just a human baseline when it comes to saying things like superhuman reasoning. Next up is benchmarks and evaluations, how we're evaluating model progress, how are we tracking progress over time. And I think there's no better way to start that than to run through how we've historically done that. And this is a systematic review that looked at, since the release of LLMs in 2022, that multiple choice has really been used as the main evaluation vehicle. The studies generally study accuracy and knowledge as the primary endpoint. They rarely use real-world data. They've rarely studied things like bias and harm. They rarely evaluated administration and workflow tasks like prescription writing. And this really sets the stage for turning towards benchmarks that I think are a little bit more translatable to the real world. And it should be noted that multiple choice benchmarks are very saturated, meaning there's not a lot of room for improvement. The models are scoring in the upwards of 90%, so there's no way to track that over time if we're already at the upper limit. And so given that we know multiple choice benchmarks are saturated, and I'd also say that medical educators have known for quite some time that multiple choice questions don't really evaluate clinical reasoning all that well, it lends the question, like, how do models perform in a more conversational real world setting? And that's what this study tried to get at, which is changing clinical vignettes into a conversational setting. And the way they did that was taking a multi-agent setup. They had a doctor LLM and a patient LLM and had them converse, and the patient would release information when the doctor elicited it. And when that was the situation in this conversational clinical vignette, you can appreciate the red to the green drops, which is when that went from the multiple choice clinical vignette to conversational, model performance dropped quite significantly. And when they stripped away multiple choice answers at the end as well, model performance dropped even further. They noted that failure modes were often a incomplete history, and rarely, about 50% of the time, did LLMs come up with a complete enough history to even determine one viable diagnosis as determined by human physicians. And again, this creates a motivation to turn towards real, multi-turn, real-world evaluation that's translatable. We'll next talk about a big benchmark this year, which was Health Bench by OpenAI. This was 5,000 synthetically created conversations that LLMs had a chance to respond in an open-ended fashion. And this benchmark tried to get at a few key gaps, which we've mentioned already, one being the lack of real-world impact, another one being a validation against human baseline, and then increasing benchmark saturation. And this was a really large-scale effort. They called on 260 physicians from across the globe to create rubrics for each of those 5,000 conversations. They created benchmarks that were highly consistent among the physicians, rubrics that were highly consistent called Health Bench Consensus, and also created a benchmark called Health Bench Hard, a subset that was really unsaturated, very difficult situations for models. They covered key themes, 7 themes, to allow to track progress over time on specific tasks. Those included things like emergency referrals, things like text-based tasks like tailored communication. They also studied context seeking, which is when models need to know when they need to know more information, and also health data tasks, those workflow and administration tasks. The main message and take home here is that you can appreciate how reasoning models perform quite well. They perform quite well on text-based tasks like communication, but they perform relatively weaker on things like health data tasks, administration, and workflow. Now, this is hot off the press data from OpenAI's press release and sort of their motivation for entering the operational workflow space. You can appreciate how on the workflow tasks, GPT 5.2 seems to show drastic improvements. And I think we'll need to have a little bit more data than what's in a press release to make a real case that this is a viable opportunity. But nonetheless, these are the types of data that these frontier labs are going to cite when they enter into spaces like this. So after Health Bench, in comes MedHelm from Stanford, and that critiqued Health Bench on a few key tenets. The first being that they felt that Health Bench was more of an advice line, asking for advice from doctors and patients, and less so on clinical tasks and clinical workflow. So that was what MedHelm really tried to get at. They tackled things like administration and workflow, clinical note generation, help with medical research, and they also critiqued Health Bench for having synthetically created data, not using real-world data. And of the 35 benchmarks in Health Bench, in 35 benchmarks in MedHelm, 12 of them had EHR data. The major performance take-home here is that, once again, we see that models perform quite well on text-based tasks. Not surprising, that's their bread and butter. They, again, perform a little bit more poorly on administration and workflow. And in this case, the researchers posited that poor performance in admin and workflow might be the scarcity of that particular training data. Now, when I, as a clinician, think about something helping me with my administration and workflow tasks, what comes to mind is having it embedded right in my EHR. And this study did exactly that. They created a FHIR-compliant environment where they put models to the test with query-based tasks, retrieval-based tasks, such as what SSRIs was my patient on this year, or they studied action-based tasks. Can you pen an order for a CT scan? Turns out, as you can appreciate, models do decently well on query-based tasks, retrieval-based tasks, but performance tends to drop, almost 30% of the top performing model, Claude 3.5 Sonnet, when it comes to action-based tasks, pending orders. So perhaps a good first use case for these models is things like performing that initial chart biopsy when approaching a new patient for an admission, rather than agentic workflows and manipulating the chart. But again, we see Anthropic making their argument for entering the operational workflow space. If we go to the last slide, you can see Claude 3.5 Sonnet scoring about 70% on the overall MedAgent benchmark. And here, Opus 4.5 now performs at 92% from that 70%. So clearly there's been some improvement. Now, you can appreciate there's a discrepancy between query-based tasks and action-based tasks. And really, they're only reporting the composite score. So who knows whether those action-based tasks are actually increasing in performance among those models. But again, we'll need more information as time plays out and the literature plays out. We'll need more information than just their press release. We shouldn't, as doctors and clinicians and healthcare workers, forget about the core ethical tenets of medicine, one of which is to do no harm. And this study got at exactly that. They looked at when LLMs give their clinical advice, how much harm can they cause? Whether that's a harm by commission, giving a treatment that ends up harming the patient, or omission, leaving out a CT scan when the patient had a pulmonary embolism. The cases that they used in this benchmark were at the level of PCP to specialist referral. You can imagine that's probably likely exactly when a PCP is going to ask an LLM for help. And then it turns out in this study, in up to 22% of cases, that LLMs can cause severe harm as graded by human physicians. Most of that harm came from errors of omission over 70% of the time. And I would say, furthermore, a key finding in the study was that the overall severe harm and harm that models caused was only moderately correlated with success on knowledge benchmarks. So it doesn't necessarily mean if you have a bigger, better reasoning model that's scoring highly on knowledge benchmarks, doesn't necessarily mean that they're causing less harm. I think there's a few key silver linings to this study, though. They compared it to a human baseline and found that the best performing models performed better than humans. And again, that's the standard of care at the moment. Another silver lining is that they created a multi-agent workflow, which is when models constrain on one another, provide different perspectives, and found that could reduce harm as well. I think the big takeaway from this study is that we should still think about in isolation benchmarking on things like safety rather than just focusing on knowledge and success and accuracy. So a few key takeaways from benchmarking. Benchmarks allow us to track progress over time. This should really lean towards using real world data as we go into the future. When I hear folks give AI talks and when I give AI talks, I always hear practitioners talk about how they want admin and workflow pain points alleviated. I think you can understand and appreciate now what the motivation is for these frontier labs entering this space but we should still be cautious. Current benchmarking and evidence shows that these models might be performing subpar on those tasks. And I think as models continue to improve, again, focusing on safety will become increasingly important as these models are becoming so fluent, it's going to be difficult to tell what the errors in judgment are. Next, we'll talk about some novel methods, which is how researchers are using novel methods to increase performance above off-the-shelf models. And I'd like to introduce my esteemed colleague, Dr. Liam McCoy. He is a resident physician in neurology at the University of Alberta. He's a research affiliate at MIT, and his research focuses on ethical integration of clinical reasoning systems and healthcare systems. Liam, take it away.
Thank you very much, Peter. So yeah, one of the things I'm really interested in as of late has been this question of how we get more sort of structural statistical grounding to large language models in practice. And I think this direction of medical event models is really exciting. I think Epic has done kind of the most profound work here, given that they have a ton of data from a bunch of different health systems in Epic Cosmos. And essentially what they've done is treated a health history of a patient like a text, just like we would predict the next token in a generative language transformer. They've done the same thing for a health transformer. So the next diagnosis, the next treatment, whether the patient dies and so on, these are all seen as sort of tokens in this long string and in this long sequence. And they were able to perform a lot of early on impressive sort of tasks here. I think what will be particularly interesting to keep an eye on in 2026 is whether we can see increasing advancement of including the medical events themselves, almost like as a language alongside the existing clinical reasoning and knowledge that we have of language models. So we have a lot of things that are able to perform, we have a lot of sort of clinical knowledge, but can we end up grounding this with the step-by-step what happens with patients? Another area I've been really excited about this year has been the multi-agent approaches. I think this paper by Microsoft is one of the most robust examples of this. They essentially used a panel approach simulating multiple different physicians, one selecting a test, thinking about things like appropriateness, one interpreting the results of those tests, an agent sort of looking for conflict and consensus between different agents. And they found not only some improvements on diagnostic performance, they also found improvements on things like the sort of stewardship of tests. I think this is a really exciting area because it will allow us to hopefully instantiate agentic personalities that allow us to more carefully think about the various things that we need to think about. Maybe, for example, you have a prescribing bot that has another little pharmacist bot that's aware of the shortages of medications in your institution, for example. And I think there's a lot of potential here. And we've seen not only in medicine, but also with things like Claude Code, that these multi-agent approaches really have taken the world by storm in 2025. But as our next paper shows, there's also challenges here. I think there's new problems that are almost like computer-computer interaction problems in the same way that we have human-computer interaction problems. So I quite like this article because what they did is they broke down clinical decision support into a number of areas: info gathering, info interpretation, diagnosis generation, and diagnosis selection. But they found that even if you picked the agent that was individually the best at each of these tasks, like Claude might be better at one, ChatGPT might be better at another, and so on, just putting all those agents together actually had a severe degradation in performance. So there was issues with increased hallucination, issues with challenges with communication when you had multiple different agents passing information back and forth between each other. And I think this, again, raises concerns that multi-agent has the benefits as shown in the Microsoft paper, but it also has its downsides. And we really have to decide kind of on a case-by-case, event-by-event basis, is the juice worth the squeeze to have agent-to-agent handoffs versus just having one larger end-to-end agent? It really remains to be seen the extent to which multi-agent is going to remain a core approach in the field versus going to be subsumed by longer reasoning traces and more powerful baseline models. Another big area of interest this year has been multimodality, having models incorporate both imaging or ECG or photos of patients' wounds or fractures and so on with other clinical context information. I think this is where things have really taken a departure in 2025 from a lot of previous work that either sort of had subtle statistical associations incorporated in or just used the imaging purely directly. So this was another Google AMI study. And what they did is they had their existing diagnostic pipeline that Peter had discussed, but they added the ability to ask for imaging and interpret imaging. And they found that once again, their models were able to outperform primary care practitioners on that interpretation, which is certainly quite impressive. One of the challenges in multimodality, as we see in this next paper, is that it can be really hard to get good, high quality, well-labeled data sets for multimodality. What this paper did, this multimodal transformer paper in oncology, it showed that actually you need a lot less of this high quality labeled paired data than you would think. So they trained on 50 million pathology images in an unsupervised way, 1 billion text tokens in an unsupervised way, and then just did a fine tuning at the end with 1 million image text pairs. So that's only 2% of all of their images actually having any text explaining what was going on with them. And they were able to find really substantial performance improvements in this process, which was, again, quite impressive to see here. And I think this is providing some hope that with these novel methods, we might actually be able to get a lot more out of these massive, massive amounts of unstructured data that we have in health systems, and that we might only need to do very high quality labeling at the post-training stage. This also provides hope, I think, that methods like the medical event models with Epic that were shown earlier, again, could actually be a lot more scalable than had been initially feared. But there's challenges when it comes to multimodality. Again, there's issues with benchmarking. This great paper essentially took a bunch of multimodal questions, a bunch of multiple choice questions, and then they completely removed the images from those questions. We had assumed that these benchmarks were evidence that the models were doing a good job of looking at the pictures and understanding what was going on in the imaging. But actually the models performed almost exactly as well with no images involved whatsoever. So a lot of the work that has been done, is probably contaminated by the fact that models are just very, very good at answering multiple choice tests. In addition to this paper, there's other papers that have shown that you can make up a fake organ system and write multiple choice questions about it, and it can still get these completely fake multiple choice questions right. And if you ask it why, it'll fabricate its reasoning. So I think we need to kind of hold our horses when it comes to multimodality and recognize that we really need to develop better, more robust benchmarking methods going forward. So another sort of interesting area of focus this year has been this question of reasoning. Are we able to understand clinical reasoning just like models are improving in terms of the reasoning on code, et cetera? This paper had what they call the medical process reward model. So instead of just rewarding the model at the very end for did you get the right diagnosis, it actually decomposed clinical reasoning step by step and then looked at each of those steps. Did this make sense? Did this make sense? Did this make sense? Did this make sense? Were these aligned with the actual underlying guidelines? And they were able to find significantly improved performance when you did this process reward process along the way. Although again, this was done on relatively small models, so it remains to be seen how much this sort of in reasoning trace assessment and reward is going to become relevant at the scale of frontier models where it become quite difficult and quite expensive to do. And the other challenge, again, going back to benchmarking, is that there is, this assumption that models have been reasoning, but this paper really disaggregated these questions, found that a lot of these questions are actually purely knowledge questions. Only about a third of the questions in our various benchmarks really are genuine multi-step reasoning questions. And as predicted, when the models are actually asked to reason in these complex scenarios, their performance drops substantially. Although they did show some hope, similar to the MedPRM model, where if you fine tune on examples of high quality reasoning and you're able to develop examples of high quality reasoning, you're able to improve both the accuracy and the robustness. So I do think it's a tractable target. So in terms of final takeaways from this section, I think first up, these multimodality is going to continue to be increasingly important. And I think that the patient's clinical trajectory is one of the most useful, interesting sources of multimodality that we have. including this information both in process reward models and also multimodal models is going to help us to get sort of a nice grounding medical knowledge and more statistical approach beyond the sort of linguistic clinical reasoning that the models already excel at. I also think that multi-agent approaches are very exciting, but again, they bring their own challenges. We need to make sure what we're doing is worthwhile. And clinical reasoning is unique, it's complex in many ways, and it's worth optimizing in its own right. There's been a lot of ongoing work over the last 50 years to improve the optimization of clinical reasoning for human physicians. And I know a lot of my work with Adam Rodman and others has been focused on, okay, what can we learn from this history of medical education and assessment? And I think in 2026, we're going to see this really start to make an impact on the reasoning of the models at the frontier.
Awesome. Thanks, Liam. Next, we'll jump into AI and clinical workflows, which is getting into the nitty-gritty of that human-computer interaction. What happens when we put doctors in front of LLMs in the clinical setting and in controlled settings? And so thus far, we've shown that models have strong reasoning capabilities, and again, at least on controlled tasks, but how does that augment physician reasoning? And we should note that a lot of times studies separate management reasoning from diagnostic reasoning. The reason for that being is that management reasoning is a little bit more fluid. The management of a patient can be subjective on a case-by-case basis. You can imagine a type 2 diabetic being managed quite differently among two physicians, whether they use different medications, introduce insulin at different time points in the patient's journey, and both deemed to be accurate. Diagnostic reasoning, on the other hand, is a little bit more binary. Either the patient has type 2 diabetes or they don't. And so that's the real reason why a lot of studies separate the two reasoning traces. But back to this study and management reasoning, physicians were randomized to use GPT-4 versus physicians with just conventional resources like UpToDate. And what they found in this study was that using GPT-4 significantly improved management reasoning compared to physicians with conventional resources. I think another interesting finding from this study was that physicians plus GPT-4 didn't necessarily outperform GPT-4 alone, and that was non-significant. And so it really makes you wonder, is there perhaps some suboptimal teaming going on that we're going to explore? Jumping over to diagnostic reasoning, in a previous study, just like the one we just looked at, where humans used GPT-4 versus physicians with just conventional resources, there wasn't that signal that we expected to see. There wasn't a statistically significant increase in diagnostic reasoning performance. And again, makes you wonder, in that case, was there something wrong with that human-computer interaction that resulted in that lack of improvement? And in this study, they tried to get at exactly that. They modified GPT-4 to produce a joint synthesis, highlighting points of agreement, highlighting points of disagreement, critiquing both the human and LLM reasoning traces. And they tried a couple of different workflows, one being physicians first, one being AI going first. Turns out it doesn't matter all that much who goes first, but what does matter is modulating GPT-4 in such a manner that actually gives physicians that diagnostic reasoning boost we expected to see. And additionally, you can see on the right, the small tails here. So raising the floor, preventing those significantly poor performing cases amongst physicians. And I think what this study really highlights is that optimizing the human-computer interaction, not just optimizing models, could probably yield some clinical reasoning benefits. We've showed that in vitro, if you will, that AI augments human performance. How does it work when we go into the real world? And this was a really large effort this year by OpenAI. They teamed up with Penda Health, a group of clinics in Kenya. And in this study design, they put GPT-4 as an AI consult. They ran it silently in the background and provided traffic lights, green, yellow, red, at standard touch points in the encounter for physicians, such as after documenting the HBI. And this was to alert doctors whether their documentation, whether their diagnostic or management reasoning was on the right track or not. And I'll say that this study was a little bit much of a prompt engineering exercise. They made GPT-4o very context aware of the Penda Health system. They also gave it several exemplars for each color, what should be deemed a mandatory stop as a red, what should be let go as a green. And their primary outcome with this study was to see if there was a relative risk reduction in clinical errors by physicians using AI versus physicians who didn't. And they found exactly that. They found that humans plus GPT-4o showed a 16% relative reduction in diagnostic errors, 13% in treatment errors. They also argued that if this was deployed on an annual basis in the Penda Health system, that they could thwart nearly 40,000 clinical errors a year. They also, on the right side of the screen, you'll see here that they made an argument that doctors learned over the course of the study. Those that used AI got less red alerts up front, so perhaps they learned to avoid documentation errors, reasoning errors up front in cases versus the group that didn't, that remained flat. And so I think this shows evidence of strong real-world clinical decision support. We need to, though, see evidence of a more generalizability, because this, again, was very context-aware to the Penta Health system. Now, the evidence for CDS extends just beyond general medicine. This was a study out of Germany involving 460,000 women, where radiologists had the opportunity to read mammograms with an AI safety net. Basically, what would happen is if the radiologist read the mammogram as normal, but AI thought something was suspicious, they would get this safety net alert saying that, hey, do you want to review the AI mammogram to see if there's a suspicious lesion? Turns out the radiologists accepted this in 25% of cases, changing their read from normal to suspicious, which over the time of the study period resulted in 200 breast cancers that wouldn't have been caught otherwise. And that resulted in an increase in the breast cancer detection rate per 1,000 women, statistically significant. And I also think an important caveat was that it didn't significantly increase the recall rate, which is, if anyone knows anything about mammography and screening, it's the recall rate and subjecting patients to unnecessary biopsies for benign lesions that causes a lot of harm. And so I think that was an important underlying finding. And additionally, they found that the positive predictive value of a recall biopsy was a little bit higher in the AI group than with radiologists who didn't read with AI. And again, this shows a great example of clinical decision support in a medical subspecialty that impacts real patient outcomes. So we've gone through a few examples of human AI teaming resulting in augmented performance, but is this interaction optimized? And I think, after all, the fundamental theorem of informatics states that humans plus machines outperforms either alone. And I think, of course, we would all hope for the ideal state where we complement one another. I know when I'm wrong and AI's right, and vice versa. But in reality, humans and AI, as we've shown already, often doesn't outpace AI alone. And that was shown in this study, looking across over 50 studies of human AI teaming. You can appreciate on the left side that we generally beat humans, erring more towards humans than machines, whereas on the right side, generally equal. We're not really outperforming machines alone when we're teaming with AI. And I think the lack of reaching that ideal complement state brings focus back on the human-computer action and workflow design. And these researchers tested a couple of different workflows. They found that the simultaneous approach might result in a little bit better performance, but really, is that humans just using automation bias because we know we can't beat the model alone, or is it that simultaneous teaming is a more fruitful environment for reasoning? And I also think that the greatest gains are likely to occur with optimizing workflows and limiting overlapping biases between the two of us. And I think that might be a little bit difficult because, after all, these models are trained with our data and may contain our underlying biases. So getting that complementary state might prove to be a little bit difficult. We shouldn't just blame models, though. We should, as practitioners, be aware of our own pitfalls at times, and physicians are, in this study, vulnerable to automation bias. When injecting false reasoning traces in a diagnostic reasoning study, physicians who were exposed to those false reasoning traces from LLMs actually underperformed relative to the physicians who weren't. And this was even with voluntary consultation of the LLM and equal consultation rates between the groups. So showing that physicians really might be just deferring to models some of the time, at least, resulting in decreased performance if those models happen to have false information. Another pitfall a lot of people are talking about is the risk of de-skilling. In this study, this was cleverly done. They looked at a study within a study. The initial study was deploying AI to see if it could help GI docs with increasing adenoma detection rates and endoscopies. And what they did was actually look at before AI was introduced, and then looked at the group after AI was introduced, but specifically selected cases that weren't done with AI. In this study, they found a 6% absolute reduction in adenoma detection rate after AI had been introduced, which shows a little bit of a signal that there might be some de-skilling. They did a multivariable analysis and found that it was still significant. So really makes you wonder, is this good or bad? I think that's within the eyes of the beholder and up for debate on a case-by-case basis. Now, switching gears, this wouldn't be a good year in review report if we didn't touch on ambient scribes, which are being rolled out US-wide all over the place in healthcare systems. And this is a study out of JAMA, which reported survey data after physicians had been subjected to ambient AI for 30 days. And you can appreciate all of the significant p-values. Physicians subjectively report decrease in burnout, increased attention to patients, reduction in documentation after hours. But when it comes to randomizing versus the control group who doesn't use ambient AI, turns out that the objective data shows that the time savings isn't all that impressive, on the order of about 20 seconds per note, which can equate to maybe 20 minutes per day, which the authors argue is on par with human scribes at the moment. Now, these studies still show that subjective decrease in burnout, and I think the likely reason for that is you can probably appreciate it's probably a less cognitive task load if you're reviewing a note than writing one from scratch yourself. And so I think that's probably why we're seeing that subjective signal. But I think the efficiency is yet to play out. And I think perhaps the efficiency might increase, those objective improvements might increase once these ambient AI scribe companies delve into downstream workflow tasks. And we've already shown that they perform quite well at text-based tasks, so perhaps prior auths might be the first use case. We've shown on MedAgent Bench that pending orders, doing those action-based tasks might be a little bit down the road, but perhaps text-based might be the first use case. And right on cue, you see a couple of days ago that one of the biggest ambient AI scribes teams up with another company to bring those prior auths to life during that clinic visit, pulling in payer data to give the information that the provider would need in order to fill out the prior auth and the requirements right there in that interaction, rather than reverse engineering down the line once the visit is over to meet those prior auth requirements. So some takeaways from this section are that I think the fundamental theorem of informatics might be under siege a little bit. We don't see a lot of evidence of humans and AI outpacing AI alone. And I think that suggests that we need a little bit more work on optimizing that human-computer interaction to see if we can reach that more complementary state. And I think bridging on that, we need to see more examples of co-pilots, just like the Penda Health study, to study downstream patient outcomes as a result of what we're seeing as seemingly augmented performance. And I think, again, lastly, ambient AI scribes are yet to make their mark from an objective efficiency standpoint, but I think the addition of those downstream workflow tasks might be likely to change that narrative. So we'll dive into patient-facing AI, which is an exciting landscape for patient engagement. And we'll start off with another Google AMI study. Again, Google really hit the scene in 2025 with conversational AI, patient-facing AI, and in this study, we'll focus on the patient perspective. How did patients like talking to AMI when blinded compared to PCPs? And in that blinded simulated setting, they found that AMI was more empathetic than PCPs. They found it to be more honest. They had higher confidence in their care. And so once again, we see some evidence that, at least from a patient standpoint, that they enjoy conversational AI and the convenience of it. But when it comes to patient-facing AI, we should have a little bit of pause for safety. And in this study, they looked at whether LLMs give advice. They put patients in front of LLMs in a blinded fashion and in front of doctors in a blinded fashion and had them react to medical advice. And whether that advice was from a doctor, from an LLM, the patients couldn't tell. Whether it was good advice or bad advice, the patients couldn't tell either. And so I think equally important, as you see on the right side on the Likert scale, they're equally likely to seek medical attention and act on that advice, whether good or bad. And so this was just using GPT-3, and we all know how much more fluent models have become since then. And I think we're not out here performing the Turing test on all our patients and consumers. They'll likely know where they're getting their information from, whether it's from an LLM or doctor. But I think this study really highlights that patients cannot be assumed to play any oversight role in this process and really raises the bar for safety. Now, patient-facing AI is a consumer AI and consumer apps is a $70 billion market and a very highly commercial space. And I think also a space with a lot of competing interests. Companies might be interested in endpoints like user engagement, profitability. And I think that might come at the risk of undervaluing things like real patient outcomes, objective outcomes. And I think this is a great example of refocusing on objective outcomes. This was using a coaching agent, an AI agent, and a mobile app, and a Bluetooth weight scale for pre-diabetics. The AI sent push notifications for activity. They randomized compared to human coaches And they found that based on objective endpoints, A1C, weight loss, physical activity, that there was non-inferiority. And I'm sure we all can appreciate just the scalability of AI coaches and how we might be able to address barriers in care and access to a very labor-intensive venue such as coaching. And I think that similar apps in the future, when studying their outcomes, should equally focus on improving those objective outcomes. After all, when clinicians are seeing a patient that has a new tool, that's what we care about. We care about those objective outcomes and making a difference in their lives. We've also covered that the bread and butter, as we showed on the benchmarks, is the model's ability in text-based tasks. And here's a great use case of reducing discharge summaries, the health literacy of discharge summaries. When patients were exposed to this, they felt that they had an easier time comprehending it, comprehending what happened to them. They had increased confidence in their understanding. And I think that as we move forward in deploying LLMs, this might be another great use case with some oversight to show that LLMs can bridge health literacy gaps. This study really showed that it helped the most in patients with lower health literacy. Another great example of text-based tasks is translation services. This was GPT-4o translating from English to Spanish for patient instructions, and it was found based on standardized rubrics that it was non-inferior to professional translators. Now, this is Spanish in a major language, and there's likely a lot of training data, but you can imagine that if you were able to take resources away from human Spanish translators and put them towards less well-represented languages, that in and of itself, that might be an advantage. So some takeaways for patient-facing AI, we've seen that patients respond positively to conversational AI. It's been shown to be, with the Google studies, translatable into adequate diagnostic management, reasoning management, some really feasible plans. Patient-facing AI, again, is a new landscape for patient engagement, but I think must come with some serious safeguards, as we've shown that patients can't be assumed to play much of an oversight role. And new healthcare applications should focus less on things like user engagement, profitability, and again, refocus on improving patient outcomes. Next, we'll talk about applied AI and demos, which is use cases and subspecialties, as well as some new tech that might be down the road, and Liam's going to take you through that.
Yeah, absolutely. So I think, as we are seeing, AI is very capable in a number of different healthcare settings. But now the real question is, what happens when the rubber hits the road? What happens when you actually deploy? As Mike Tyson said, everybody has a plan until they get punched in the mouth. And I think when you try to do broad scale deployment, that's where those real challenges arise. And so I really like this paper from the NHS where they showed the rollout of a non-LLM based stroke AI detection system. This was over 500,000 patient encounters at over 107 different hospitals. And they found indeed that there were strong benefits in access to endovascular thrombectomy, as well as the speed of that thrombectomy access. And in particular, these benefits were found most at the community hospitals that we might expect to have the least sort of technical sophistication and support. And so I'm hopeful that there's going to be continuing results like this that are going to show that AI can really have an impact in true deployment. We also see, again, this kind of overlaps with my methodological thoughts earlier. There's been a question of whether it's best to have a number of small task-specific models or whether we should just throw everything into the model and shake it around and see what tasks come out. And I think this paper definitely favors the latter. So they were able to train on over 100,000 different scans on a range of different tasks, including things like diagnosis and prognosis, but also things like image reconstruction and image enhancement. And they found that indeed the models got better at these various tasks by doing the multitask training on them. And so, we talked about multi-agent earlier. There's questions about whether we're going to have narrow task-specific models with a tool use LLM, kind of like we have with something like Claude Code. But I think this points to the idea that at least in certain narrow areas, maybe the mega model approach will indeed be beneficial. So it's quite an impressive paper. We also have another paper looking at stroke prediction from the retina. This was, again, a very large data set from a group out of China, I believe. And what they did is both predicted patients who had silent strokes, so strokes that would show up on imaging, but with no clinical sort of circumstance. Then they also predicted who was likely to have a stroke in the future with the idea that you could find these people and begin intervention faster. And I really like this sort of work because, I think when you're working in a very imaging abundant setting, you think, oh, we'll just get a lot of MRIs, but actually having ability to access non-invasive imaging, things like retinal scans is really, really useful. Even in Canada, we have about a third of the scanners in the United States. So I can think of a lot of patients who I'd love to be able to just predict based on retinal scan. Although, again, we have to be cautious. I think Google has an excellent paper they released a few years ago showing that their similar retinal scan work absolutely fell apart when deployed in the real world in Thailand. So it's a complex space, but I'm excited about the prospect. And again, the power is definitely there. Further on, we also have this a culmination of many years of work from the folks out of Cedar Sinai, which was Echo Prime. This is a massive video-based language foundation model trained on millions of echocardiograms. And what it allowed the models to do was do complex multi-pass echo interpretation. So while previous echo interpretation would have been just based on, okay, look at this appropriately selected view, tell me if there's microregurgitation, this model actually allows the AI to select what view it wants to look at and then look at the parts of that view that are appropriate, which is also really useful from an interpretability perspective and possibly down the line in terms of having automation of that actual data gathering process. So quite exciting work, and I'm excited to see this continue to scale in other ultrasound-based areas. Finally, we have a series of demos. So this is the Chatty HR, this out of Stanford. I think we all have that vision of, gosh, I wish I could just ask my computer what's going on in the chart. When was this patient first diagnosed? What has this patient tried for their diabetes, et cetera, et cetera. There's a lot of operational challenges and privacy challenges to that. And the Stanford crew's done a really good job with Chatty HR, as you see in this GIF here, of just allowing you to ask questions back and forth, use these models in a safe, HIPAA-compliant environment with access to the chart itself. There's ongoing studies to see, how is this working in the real world? How is it starting to fall apart? But in addition to the Stanford group, other people like the group in Belgium have done similar work, as well as a number of commercial entities. And I think this is going to be a big space to watch in 2026. We also have additional work that's being done on primary care physician to specialist consultation. This is the SAGE project. I published a paper about this, as well as some other folks from our lab, the various sort of pieces we're doing here. Essentially, the goal is to streamline the PCP to specialist consultation model. Stanford has had these asynchronous consultations for a while, but asynchronous consultation is really challenging. As anybody who's gotten on the phone with a specialist knows, there's always a lot of follow-up questions, sort of specific things, specific information at the point of care. And if you're doing it asynchronously, like via letter, you might not find information back for a couple of weeks. So we've identified a number of different areas where AI can be helpful, whether that's generating the template, helping you to fill the template, helping to provide some preliminary initial feedback before the specialist can review. I think these are all really exciting areas. And again, I think some of the first places where it really feels like we have full-fledged physician-like agents are going to be in these existing scaffolded settings, like asynchronous consultation, and then eventually things like telehealth, as Google's Amy is focusing on. Finally, going back to the no harm study that Peter had discussed earlier, our colleagues have done some really amazing work creating a high quality interactive dashboard. And I think the PDF to printed format of papers is never going to capture the depth and breadth that we need to. And so we're quite proud of the visualizations we've set up here, where you can look at a lot of different models, look at ensembles of models, and see not only how do they perform in kind of a 1 to 100 scale, but also how do these models sort of place themselves on the personality in terms of omission versus commission, in terms of aggressiveness, in terms of willingness to order tests, in terms of willingness to order interventions. I think this is an interesting foundation, and a lot of our work here is going to be over the next year is going to be in adding our various different benchmarks onto these dashboards, allowing us to figure out things like, okay, what is the personality of the model, and can we tune it so the model is how we want it to be? I'll linger on the next slide for just a second before going to never mind, I added in the QR code, but I guess it didn't make it into the final deck. So go to bench.arise-ai.org if you want to see that no harm benchmark. So some final takeaways here. I think, to answer some of the questions that have popped up in the chat, I think a lot of the long form transformation of the field is going to be driven by what the frontier models do. Where GPT-8 is or GPT-9 is something that is unknown and is at the scale of a lot of these massive labs. But I do think that the short-term paths to impact and the ultimate paths to impact are going to be very context specific, very setting specific. Things like Chatty HR and other similar projects are a great step in the right direction, because a lot of the low hanging fruit are these administrative tasks, these workflow tasks. One of the ways I've started to think about it is if you had 1,000 medical students or 1,000 administrators in your computer able to perform these tasks for you, what would you get them to do? And as a mentor of mine said, AI can make us more smart, or it can make us less dumb. I think there's a lot of things that are in the less dumb category before we start getting to the medical super intelligence, more smart category. There's a lot of areas where we could use a second check or a kind of a tap on the shoulder. I think imaging is going to continue to be one of the big areas. It's the most developed sort of scientifically and commercially, especially when we start to add in this abundant, low cost, non-invasive data. And I'm really excited to see the various trials necessary to see how these things continue to function in the real world.
Thanks, Liam. So we'll touch on some final takeaways, and that's a great note to end on that Liam just expressed there. And I think one of the major takeaways is that model capability is definitely increasing. We've seen over and over again in all of these studies that models have become very capable on specific tasks and controlled settings, and we should really set our sights on model impact. And I think that'll come from real world evidence, real world prospective trials. Next, I think we do see some evidence of the jagged frontier. Models perform seemingly at superhuman levels on some tasks and seemingly exhibit poor performance when randomness is introduced. And we should again maintain caution when thinking about model deployment in novel environments where models can be quite frequently introduced to uncertainty. I think this year will be a year of significant gains in workflow and administration tasks, which again have been historically understudied, historically under benchmarked. We've seen already in 2026, going back to those initial slides, OpenAI and Anthropic entering this space with some force. Next, we've covered patient-facing AI. I think it's going to continue to grow, but again, safety here is paramount as the patients can't be assumed to play any oversight role. And lastly, as we opened with, the FDA is already approving AI tools. And I think akin to how doctors are used to integrating new drugs on an indication by indication with backing evidence, I think perhaps new AI tools might be adopted in a similar fashion, in a task-specific basis with backing evidence so that doctors trust it. We'll end on a little bit more fun here with some 5 predictions, and here they are. So with all the movement into workflows, I think perhaps we might see the first malpractice lawsuit where AI plays a major role. We did make the second prediction back in November of 2025 when we were creating this deck, and just 2 weeks into 2026, it's already proven to be true in that consumers will increasingly have access to things like ChatGPT Health from the major frontier labs. With the third prediction, I think frontier models will continue to, again, outperform humans on benchmarks. And again, new research will focus on that optimization of the human-computer interaction. The fourth one is something specific to me. I really enjoy reading the chart and what other doctors thought about patients that I've seen, figuring out how they reasoned about it, what they thought. But if greater than 90% of the clinical text is ambient AI, can I really be relying on what my colleagues thought about in that case? And then lastly, as we've seen a little bit, the ambient AI players, I think, are going to push the boundaries of what they're capable of and delve into administration and workflow tasks. So here's our disclosures. And we'd like to thank all of our supporters throughout our research. And I'd like to thank you guys all for attending this talk and this whirlwind through the state of clinical AI in the past year or so. I hope this provides some context of all the madness that's going on in the current events. And of course, as this is the inaugural version, we'd love to hear your feedback. And we've got a form here and that you can click on the link in the actual report that's on this QR code. And we are just happy to take your questions.
Fantastic. We're pretty much in there. The full report's online, and they covered maybe half of what's in the actual report. There's just way too much dense stuff, and it's moving so fast. We're trying to cover some highlights. A lot of this is orchestrated by Ethan Go. Would you like to just give a closing comment for us since we don't have too much time? I saw there were questions along the way. I tried to address some. Peter's done a lot of this review. You can reach out to him, to any one of us. But Ethan, can you come to the phone and just give us a closing commentary of what you thought about this report and where you think this is going next?
Is here good or should I go over the?
This is good. You're good.
Well, thanks everyone for coming. As you can see, it was an enormous team effort. I think even for us researchers, right, there's so much to keep up with. Clearly, the pace of what's been going on adopted is outpaced, right? I think some of the ways the tools are being used. I think all to say that this is something that we hope to put out year after year as a sort of service to the whole community. And yeah, I mean, there are many ways to engage with our group. And I think if you scan the QR code, it will lead you to the full report. So don't worry if you didn't manage to capture all the takeaways. The full report, I think, is over 100 slides. And I think, like Peter, as John mentioned, we welcome any sort of feedback to further improve this. And again, I think the goal, if you sort of format it, was Google Slides, right? That is deliberate. And the reason is because, again, right, who reads sort of papers, right? Then preprints, abstracts, just too much, right? So what we tried to do was kind of summarize it into a 2-level takeaway. And then I think that really helps you to try and digest, right? And then, you can always follow up and ask us more questions. Thank you. Yeah.
Thanks, Marie. Thanks, Liam. Thanks, Peter. A great job. Well played tour. And there was still more to cover, but we had to cut it off at some point. Thanks all. We'll continue the discussion. Take care.
Thank you.
And over 270 people online. I think that's a record for us.
It also somewhere else. So you know, I'm definitely going to engage about it. Take a look, take a look. I think that is that even useful?
Product and spin it out. Sorry?
Yeah.
Yeah.